So for those online and those here, if you don't know our guests, they're from Converging Health. Converging Health is a consultant group that is working with us, for us. They were brought here by us. They're family docs and teachers of family medicine and are here to help us redesign our ambulatory care network and family medicine program to be more efficient and more effective and take better care of our patients while trying to make everyone happier as a provider. So the quintuple aim. So two speakers today. Dr. Scott Conard is a family physician from Texas. He has a tremendous amount of experience running family medicine groups and is a data guru for us here, helping us bring medical information to better care for us, our patients, well, us too. So. And Dr. Mike Tuggy is a longtime family physician educator. He was a family medicine program director for how many years?
20.
20 years he survived. I only survived 17 as a program director. So 20 years he was able to survive you guys, so that's admirable. He's former president of the Program Directors Association and was on the Family Medicine, the AFP Council for Family Medicine for America's Health. See, I got it down. I remembered all that in my head. So we welcome you all. Thank you.
Thank you. All right, thanks, Alan. It's great to be here, and we're going to do a little bit of visioning this morning. How many of you are residents still here? Okay. Yeah, all right.
I'll always be a resident.
Dr. Tulo raises his hand, yeah. So, but yeah, the future is coming, and the future is here already in many parts of healthcare, and especially in primary care as it's evolving, except there are a lot of growing pains. We're going to talk a little bit, we're going to talk a bit about that, about this advanced primary care model again, and kind of where we are in this transition here in Jamaica, and where we want to go. And so Scott and I are going to walk through that, some of those ideas with you today. But the objectives today are to really think about this mindset shift of going from fee-for-service, which is kind of what a lot of American medicine still is about, to a high-value care model, which is where we're headed. And just to pause for a second to think about the life of a fee-for-service clinician versus a value-based care or high-value care physician. And really what we're moving from is this idea of seeing patients just that come in the door to actually a risk model where you're actually reducing people's health risk. That's the primary goal in the work we do in healthcare, to improve their health and improve their outcomes.
Can I make a quick comment? You know, it's really strange that the largest economic engine in the United States of America is a complete mismatch. You have what the people who use the system want, which is really great care at a fair price, and you have what the people providing care get paid for, which is higher cost and higher volume. So there's this complete disconnect between what people want that are paying for the care and what people are providing with the care. And the way that the government and whether the state or federal have decided they're going to solve the problem is they're going to put the providers, the clinicians, and the healthcare systems at risk for the care of the people. So when you do that, what happens? It flips. So now, instead of higher price and more volume, it's about taking better care of people. And all of a sudden, the incentives have changed, and so you've got an alignment of the clinicians and the people buying care. And so you're going to see your lifetimes will see this transformation. Now, primary care may be different than specialists because really in the system, the people who need to have that alignment are primary care. Specialists are proceduralists. You know, they know the most about a disease or they know the most about a surgery or a procedure. They're not really oriented or paid for taking care of a whole person. So it may be the system breaks down where you get primary care that's at risk and you have specialists that are just getting paid fee-for-service like they are now. That's okay as long as the primary care, the clinicians actually have a significant role in deciding and choosing with that person what kind of care they receive. So we've got this bizarre schism today that's going to be fixed in your lifetime, and you're going to have to go through that transformation, that transition. Well, you're fortunate if you're related to Jamaica because they already have had the financial incentives completely flipped. They're 100% at risk for the care of individuals. But even though the financial model has shifted, the way of practicing medicine has not yet been completed. And that's what we're here for, is to help particularly the primary care folks shift the way they think about what they do and quit thinking about volume and how much you get paid, and really make it about how healthy is this person, how much does this person understand what is going to influence their lives in terms of how long and how well they live, and what does our relationship have to change to in order to accomplish that? Because we just went, in that moment, in fee-for-service, you get paid for sending in a CPT and an ICD-10 code, right? It doesn't matter whether you made the person healthier or not. You just send in the codes, money starts to fall out of the sky. But in the new system, it's how healthy is that person, which requires you to take people with high hypertension, diabetes, high cholesterol, stage 1 cancer, stage 2 cancer, early degenerative joint disease, and get them to change their behavior before they feel bad. So you've gone from a symptom treater to a risk manager, which means the relationship with the patient has to go from a, here, come in, see me, I'll throw some ICD-10 CPT codes over the fence and get paid, to, I gotta have a relationship with you. I've got to really support you in living your life a different way, and the trust between us has got to be, and not just me, but the team. Because if a fee-for-service doctor were to do everything they had to do every day on the 20 or 25 patients they see, they'd have to work 23 hours a day. And what do? They send over CPT and ICD-10 codes. They don't do the majority of the work. If you look at preventive care in the United States right now, it's pretty dismal. So in the new system, you actually have to do all those things if you're going to reduce the health risk. So what the clinicians, you, are going to figure out really quickly, like lightning speed, is I don't want to work 23 hours a day, but yet I've got to get all this done. How do I do that? And the answer to the question is what Dr. Tuggy is going to tell you about.
Which goes on to our next slide. Part of this is visioning what does this fee-for-service day look like, which I think Scott just described that really well, which is, and I've worked in RVU-based systems where you just see patients and you just count the widgets. You see them, you bill, they leave the office, and you can forget about them until they show back up again. That's the way the old system worked. Now you can't forget about them because you're accountable for their healthcare outcomes and their cost of care if you're on a capitated system like Jamaica is.
Can you hear him in back? Are you all able to hear him in back?
Yeah.
Okay, if he gets too quiet, he tells him sometimes his voice drops, just wave at him and he'll talk louder.
Yeah, give me a wave, you can't hear me. So imagine your day now. This is with the new model where you start your day with a team huddle, which is, because your clinics are doing this already, many of the sites very well. You have a filtered in basket where one of your staff has already looked at the email messages that have come from, or the MyChart messages that have come from patients, and they're filtering those so that they send you just the ones you need to deal with. You're scheduled with patients who really need to see you that day. Everybody on your schedule, you look at that name and you think, oh yeah, this is somebody I probably need to see. This is not going to be a wasted visit for me. Your team is managing the low-risk patients that have contacted you for some sort of help, managing what care needs they have if they don't need to be seen directly. And they're prepping the visits, doing pre-visit prep with maximal efficiency. So when you walk in the room, if you're seeing a chronic disease patient and they're there for a diabetes follow-up, the orders are already pended for you. You just review those orders, you can sign off the ones that you want to do and cancel the ones you don't need. Your documentation is lean and efficient, which means your clinical notes don't have a bunch of garbage dumped in them. What they have is, here's what the patient came in for today, here's the diagnoses, here's the care plan for each diagnosis, following the 2021 standards that CMS has put out. And then during the day, you may have your care manager who's managing your highest risk, most complex patients, can come up to you and say, hey, I've got a question about Mrs. So-and-so. She's got, her diabetes is out of control. What do you want to do with her insulin this week? And I can let the patient know. And then she contacts the patient and adjusts that patient's insulin for you. And then you leave the office at the end of the day knowing that you have done really great care for the patients you've managed, and you have a good sense of the pulse of your population you take care of. All that's done through teamwork. So the key transformations we're really talking about here is clinic teamwork that changes the way you manage a population, instead of you just seeing the patient in front of you and not really working as a team member. This model of care really has targeted risk-based outreach. And what that means is, you have a population of patients on your panel, Some of them are high risk, some of them are emerging into a high risk state. And what we want to do is target those people before they get sick. And you have to know who those people are. And that's the work that we've been working with in your data, is to give you that list of patients in your panel that are rising, that are going to get into trouble. And really the focus is on high value work. So one of the things I ask my staff, and that we think about all the time, is what I'm doing, this activity we're asking you to do, is there any value in it? Does it provide you with the information you need or the care you need to deliver, or is it really improving your patient's health, or is it a waste of time? And if it's low value work, we want to get rid of as much of that as we can and move everything we can to high value work. And that's across the spectrum. That's not only the physician's time, it's your nurse's time, it's your MA's time, it's your ACR's time. It needs to be high value work to really be worth doing. So, the workflow that we're looking at right now, we've been doing this data integration work with Scott's and his IT team, have been taking the data from Health First and from your Epic system and pulling it into this database and being able to produce reports about the performance of your teams, but also the risk of your patients. And then we've been working with your teams and with your leadership on restructuring the workflow that's happening in the clinics so that your team members are kind of maximally effective in the work that they're doing. We've also been working with your teams and your leadership on this mindset shift, which is really important to actually think differently about your workday. And then finally, we're working on the support structures to make sure the clinic can operate in this new model. And then the last phase of this project is going to be working with your specialty care to really integrate their care more directly with the primary care teams. And this is going to be a big lift to get that done as well. So the mindset shift, remember our role.
Can I make a comment on the last slide? I want to go back to the last slides, because when you look at what clinicians, and we use the term clinician, we're talking about MD, DO, PA, NP, okay? The people who are kind of the ones that are making the clinical decisions and doing a lot of the order finalizing as opposed to pending. There's a couple of key things that are mantras I would like to just say out loud to have you all put in your mind and have them start to reverberate. First of all, is everybody works at the top of their license. Remember the 23 hours of work that needs to be done? Do you want to do 6, 8, 10, 12, 16, 18, or 20 hours of that work as the clinician? And the answer is like 6 is good for me, right? So if you take and look at what those 23 hours of work are, first of all, a couple of hours of those is administrative work, because in the fee-for-service system, you've got Big Brother insurance company looking over your shoulder saying, are they committing insurance fraud? We've got to make sure they document adequately. We've got to make sure that there are this number of elements in the history of present illness, and this number of physical exams that were performed, and this degree of clinical decision making, or they're fraudulently billing us. Well, that's gone. That's gone. That's what he talks about, lean, mean, fighting machine notes that say, here's where the patient is, here's what their risks are, here's what they need, and here's what we're going to do next, and here's their follow-up plan, right? So you get rid of the garbage and all the fluff that in a fee-for-service environment, you paste and click all this other garbage in there just so it looks like you did a lot, and you weren't committing insurance fraud. So all 2 hours of work a day, gone. Then you say, when my team works at the top of their license, what will they be doing? And you take your ACR, your PAR, your LPN RN, you take the navigator, and you ask that question, and what you see very quickly is that anything that's a protocol doesn't need 17 years of education to activate it. If this, then this. Okay, a PAR, an MAR, an LPN, an RN, they can do that very, very effectively. So you hand things off, and everybody works at the top of their license. And you don't do anything that somebody else on your team can do just as well as you can. If they can do it as well as you can and you're doing it, probably not something you should be doing. But what this requires is a new set of skills. Because in the old system, you had to be competent of getting up, getting to work, seeing the patients, and documenting effectively, and going home. That's kind of that's your responsibilities. And you had to have great subject matter knowledge in family medicine, right? Now, there's a third set of skills that you've got to have. And that is, how do you interact with other human beings effectively? In the current fee-for-service system, you can really be a complete jerk. Just goes in, takes a history, does a physical, documents your notes, tells everybody, get out of my way, let me just run through these patients and, check them in, get their blood pressure, get out of my way, I'm gonna do it, right? And then you just run through patients. In the new system, you gotta actually be a human being who communicates and says, hey, I'm gonna share the load with you all, you guys need to take this and do it, and they need to be able to come to you and say, hey, we don't know what to do here. We're at the top of our license, this is over the top, and we need your help, and you've got to be pleasant and so forth. So that's what this whole Art of Medical Leadership endeavor is about, is that when you look at healthcare systems, not Jamaica, not Medisys, but healthcare systems around the United States, physicians tend to be not the best at communicating with teams, not the best at working with teams, depending on how much time you actually spend in isolation, with pathology and radiology, and then, the social skills can go down to pretty close to zero, and you still do incredibly well. In family medicine, we're lucky, we're a little bit better, but still, you'd be amazed how many people would qualify for a DSM, what are we at now, 5 or 6, for an adjustment disorder with antisocial, mood and stuff. So you have to take it on that I'm going to become a more complete human being that's able to communicate and work in a team very well. And I don't think that most primary care physicians really, or clinicians really get, although I will tell you the NPs are probably the best at it, because they've had to work in an environment as an RN, and they really get the importance of that. And so they actually are great models in how to communicate effectively, how to educate well, and they have a great relationship with patients. Whereas most MDDOs, we tend to be more transactional. I want to get in, I want to figure out what's going on, I want to write the orders for what's next, and I want to go to the next patient. That's a transaction, that's not a relationship in the sense of I'm going to have that person really feel touched, moved, and inspired when I leave. So the Art of Medical Leadership is free for you all. Everybody can participate. It's not too late. It's never too late. You can jump in at any time you wanted to. What happens is you get a book called The Art of Medical Leadership that was written by Susan Aron and myself. And then there's a video you can watch each week, and then we have get-togethers where we all get together and talk about what does that mean for me. So it's one thing to get the theory, but then to say, okay, now what does that mean for me? And it's all about you, because what you really get is that great leadership starts with leading yourself. Great interactions with other people starts with knowing yourself and why and how things work in your life. So it starts with you getting to know you, and it's amazing with the Art of Medical Leadership. I mean, we wrote this book quite a while ago, and we started teaching this course in 2008. And I can't tell you the number of people who came up to me and said, that Art of Medical Leadership thing you guys did, I've lost 75 pounds because I got to know me and I got to understand why emotionally and in my social interactions and things, why it was coming up for me and I felt hungry all the time. But when I really got to know that, I started changing my relationships with the people around me. A lot of that energy went away and I just didn't feel hungry anymore. Or I quit smoking after 20 years. I can't believe I quit smoking. Because we teach this to everybody from the anybody who participate, from the janitor and security guard to the top doc at a clinic. Everybody learns these skills. And this is available to you right now. So it's designed to establish trust with the patient and your care team. And I'll let you take it from here, because you have a better take on this. I've got the curse of having lived it for 20 years.
Okay. Yeah, so one of the things that we're really focusing on is this whole idea of establishing trust, because when you work with patients, you're asking them to change behavior, right? That's, in order to get healthy, they have to change what they're doing. Part of our job is obviously diagnosis for people with new problems or new symptoms that have developed, but the majority of the work we end up doing is asking them to change what they do. And nobody changes behavior if they don't trust the advice they're getting, right? I mean, how many of you had patients refuse a COVID vaccine, right? I mean, we all did, right? Patients that we thought we knew really well, but the ones who really have trouble with trust are not going to do what you ask them to do unless they really believe what you're telling them is the right thing to do. The other thing about this mindset shift is that as a primary care clinician, you have to manage as much as you can. I mean, again, working at the top of your license, doing as much as you can for your patients within the primary care center. We also need to be really working on closing gaps for prevention, because like as we mentioned before, prevention is really a problem that we have not tackled well in this country, and we have to get much better at making sure our patients get screened. And then the other thing is with our really highly complex patients, we have to learn how to work with a care manager. How many of you work with a care manager, met with a care manager in care of patients in the last 6 months? 0, right? You have care managers in your system. Every system has care managers, every health system does. But I can tell you the interaction between primary care and the care management team is often very, very lean, if not non-existent. And we have to break that silo down and totally change that interaction. Because we all have very high-risk patients who need much more attention than we can give ourselves as the clinician, and even with our care team, and they need somebody who can check in on them more regularly and really make sure they're following through on their care needs. So again, the target here is to reduce health risk. So our primary job is not to move patients through quickly. Again, it's to provide high-value care. So there's new protocols that are going to be rolling out to your clinics in the next probably week or so to get those finalized, that are going to be the workflows, because again, like Scott said, we don't have 23 hours a day to do this ourselves. It's going to be putting the work on different members of the team to really accomplish the goals of high-value care, prevention, and really following through on care plans. So we need these team members to accomplish these tasks, and these workflows and responsibilities are going to help define the work of your care team members really clearly for them. And this is already happening in a lot of the centers. They're learning their role in the patient flow during the day, and also the follow-up care that needs to happen for our patients. So the other thing is, what we're seeing is that people following these protocols, the team dynamics are getting better because they actually know what their role is very clearly, and then they're also allowed to help other people out. We heard that a lot yesterday. We were at Hollis Tutor and Hollis Clinics. They were describing how when somebody was getting behind in what their role was, somebody else would step in and just pitch in, because they could see this is their role, this is their job, but because they're working hard at it, I'm seeing them working, I've got a few minutes, I'm going to help solve that problem for that team member. So those are going to be outlined and handed out the next week or so.
Can I make a quick comment?
Yeah.
So just a quick comment. Yesterday when we went, we started at St. Albans, and we went to East New York and somewhere else. They
St. Albans,
Jamaica.
Hollis.
And then yesterday we went to what was the other one?
Hollis.
New York and Jamaica first day.
At Jamaica the first day, yeah. And so we sat in a big group with all of the staff. And in the art of medical leadership, one of the things that you get is that you quit thinking about right, wrong, good, bad. You know, I know the truth, you don't know what you're talking about. You don't question the commitment of the staff that you work with, and you assume that everybody is doing the best they can with the knowledge and the experience they have. And so you actually develop a softer side, an engaging side, and pull it out of them. Every person in the clinic is a leader from literally every person. It doesn't matter if you have an org chart where someone answers to you. That's not the point. The point is that if the security guard looks at somebody when they walk in the door and they say, "We're so glad you're here today," and that person feels seen and acknowledged, that may be the thing that keeps them coming back to their future appointments. Every person is a leader, and every person has to see themselves as a leader and embrace that. When we started this, I'll never forget, about a year ago, one of the doctors at one of the clinics, I said to them, "You're a leader." And she said, "No, I'm not." Like, what are you talking about? "You're a leader." She said, no, I'm just a line doctor here. And we're like, okay, we need to rethink this a little bit. And she's now one of those rock stars in the art of medical leadership, because she sees her influence and the power she has in the world just by being there every day and being a great participant on a care team. And her care team, what we did is we all sat in a room and we said, we're going to talk about what's working and what's not working. We're going to have the courage to say out loud what's not working for us. And so it shifts it from good, bad, right, wrong, where it's about the person, to how's the system working for all of us. Because the broken thing about much of medicine is not the individuals. People go into medicine because they care. They want to make a difference. They have a heart of service and healing, but the system is so broken that mistakes are made, people die, bad things happen, and then we turn and attack the person and blame the person for the broken system. So one of the mind shifts that you will take on in your career is, how's the system working and what do we need to do to fix it so that everybody wins all the time? And I'm sure that some of you are thinking, well, but some people don't, that's garbage, let it go. Some people have been set up for failure, and when you look at them externally, they look like they made a huge mistake or they didn't care. But when people act like they don't care, it's usually because they feel hopeless and helpless, and when they did care and tried, they didn't get rewarded, they didn't get acknowledged, and they gave up. That's a leadership failure. That's on you and me as the leaders of the centers, that people would actually have that very negative experience, become hopeless, helpless. You see that with patients a lot that are obese. So I don't want to go on too much, but the point is that when we got the teams together yesterday, and we had the courage to say what's working and not working, what's working is, oh my gosh, my day is so much better because of the people I work with and the teams I have. And literally at St. Albans, several of them said, we've been doing this model now for 6 or 8 months, and I literally know what my doctor's going to say before my doctor says it. So we're starting to get this real efficiency and this real intuition, and the doctor, or the clinician's the right word, the clinician knows that things are going to happen without them having to say it out loud. And it's really a magical moment when you start to get that momentum in your clinic. So again, circling back to what Mike said a moment ago, your job, you know, dun, 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 should you choose to accept it, is to take people who feel fine, who aren't healthy, and get them to live their life a different way, right? It's easy when someone walks in and goes, oh, I'm in so much pain. Oh, well, you've got to do something differently. Okay, I'll do that. It's different than walk in and they say, hey, I got my blood work done. I'm here for my physical or whatever. What's going on? And you see they've got diabetes or hypertension or high cholesterol, and you're saying, you're at risk. And they're like, but doctor or clinician, I feel fine. And you're like, but you're not fine. And then they say, but I don't want to take medicine. And you're saying, well, then you need to change your lifestyle and eat differently. Well, I like the food I eat, you know. And my grandmother lived to 89, and I lived to 89, and she was a farmer who worked 8 hours or 12 hours a day. And I sit behind a desk, I weighed 280 pounds, she weighed 160 pounds, but I'm going to live till 92. And all of a sudden you realize if you're going to win in the new system, you actually have to have a different relationship with that human being. So how do you do that and not have to work 23 hours a day? Well, we take all the data, and Mike and I invented this, and we have programmed it. We take all the data and ask the questions a family doctor would want to know, right? And there are over 300 questions that we look at the data, and depending on how the data answers, you get a different score. And the score starts from very low, like 15, and it goes up to 300. And the more things that we see in the data that a person has that is not going well, the higher their score. So now, your ACR, if someone calls in and says, my ankles are a little bit swollen, and they have a risk score of 15, they may call the RN and say, hey, you know, this 30-year-old has a score of 18, and their ankles are a little swollen, and they can get an assessment, and they can go to their team, and they can figure out what they need to do. But if that person has this risk score of 120, it's like, we need you to come in. Like, I don't need to go back and find the doctor or the clinician and ask them, this could be a big problem. And so it takes your care team, and instead of them knocking on the door and interrupting your flow and asking, what should I do with Miss Betty Boo, who's got a little bit of ankle swelling, they automatically bring Betty in, and you get to see them that day, because really they're going into heart failure, and the first symptom is their ankle. So what you see here, this is the employed physicians at Medisys data. You can see that there's 19,887 people that are low risk, meaning that they're going to have a risk score that's low enough that if they, I've got a headache, I've got, whatever, a rash, that's probably not an emergency. But it needs attention, we need to work it through, we need to figure out what's going on, and your team can help you really make that happen. On the lower right, there's 12,365 people. These folks are the ones that if you say, how do you feel? They say, I feel fine. But you're looking at the labs going, I don't feel fine. I'm worried about you, right? You've got conditions, you've got possible cancer that we haven't done screening for. You've got numbers that are not a goal. You're not being compliant with your medication. I'm having chest pain looking at your chart. Now the fact you're not having chest pain means that you think that I feel fine and I am healthy are the same thing. They're not the same thing in you. Whereas the people in the lower left, I feel fine and I am healthy, they're probably the same thing. So your attention really starts to be on this 12,365 people, and your team's job is to change the way they think, their mindset about their health, so that they change their lifestyle and they change the way they do things, and they start to take their medications and understand why they take medications and what the medications do in their body, blah, 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 so that they don't bounce up to the 4,591 people. If I were going to have a heart attack in 30 seconds and you said, Scott, how do you feel, what would I say to you? I feel fine. And then I have a heart attack. 50% of the time as a male, I die if it's a chest pain from my heart, not reflux. And a woman, 67% of the time, according to the American Heart Association. The first time a woman feels pain in her chest from her heart, she's going to die because the smaller vessel is 10 years older. So waiting for symptoms is not such a good strategy, right? So how are you going to have that relationship that has that person change their behavior before they get symptoms? And that's really the key, and that's what the data is about, is helping you. Because if you were to try to see, this is about 60% of the population of the 1987. If you tried to give everybody, the 19,000 or in the 12,000, the same care, you'd be working more than 23 hours a day. So you have to start to take the resources and your energy and focus it on the 12,365.
Yeah, that brings us to the point too that we're definitely heading into an era where there's going to be a pretty significant shortage of primary care, and this is the reason why we're looking at this risk modeling to figure out how to manage a population, because there's no way to get all the patients in who just feel like they need to be seen if they have a minor condition that can be triaged by one of your team members, or maybe it's just a phone visit, a quick phone call back is all they may need from you as the clinician. The risk score we have has several components. We'll just go over this very quickly. When we look at the absolute risk, these are the things like the inherent disease processes that are going on in somebody. The clinical quality score, which is how good is our system taking care of that patient, how well are we executing on the care gaps, closing those gaps, making sure they're getting the care that they need. And then the flare or utilization risk, which is how well does the patient use the health system? Are they going to the ER? Are they doing urgent care? Are they just running to see a specialist before they get input from their primary care doc? All those components are tied together in this risk. And the risk score gives us a framework then to look at how to triage these patients. And then we also know too that some patients have flares in their risk score. This is the rising risk category. If they get a 20-point jump in their score, something is going on. We need to get those patients in for evaluation.
Yeah. Let me just make a quick comment here. This risk score is a primary care risk score. Like, this risk score doesn't predict how well people are going to respond to ACE inhibitors that have congestive heart failure. That's not this risk score, right? Or with how quickly people are going to go into renal failure with the GFR 47. This is a primary care risk score. This is asking how much attention does this human being need from their primary care team. So you could have somebody with a risk score of 50 who is a 40-year-old guy who never goes to the doctor, who's got diabetes, but he's not treating it, but he doesn't even know he's got diabetes, and his blood pressure is too high, and he's obese. They would have a and let's suppose that they get a cold one time, and they go to an emergency room to be seen, their risk score is going to be 50. And they're going to walk in, and you're going to go, wait a minute, we're doing a 40-minute visit on a young guy, and then you're going to go, oh my gosh, there's all sorts of things going on. Either their absolute risk is high, or they're using the system really inappropriately. So somebody goes to the emergency room for their primary care, doesn't take their medicines regularly, okay, they're going to have a high risk score, and you're going to go, but there's not that many diagnoses here. And it's because what they need is the treatment they need is to have them understand how to use the system differently. And you need time to get into their value system and find out, why the heck do you not show up for your appointments? Why aren't you getting your prescriptions filled? Why are you going to the emergency for your care? It's a different way of thinking. Like, you're probably thinking, well, that's not my job. Well, it may not be. It may be your navigator's job to spend that 20 minutes to teach them. That's cool. That's fine. That's them working at the top of their license. But the risk score is about the person's behavior, how well the system is engaging that person in getting their preventive and their chronic disease services, and their risk. So it's a whole person risk score.
The other thing we've been doing is introducing this concept of a high-value visit. How many of you have had high-value visits on your schedule? Know what those are? Yeah, so the residents wouldn't have this yet, but for those on the audience remotely with it, this is definitely happening. What we do is we've given people more time with complex patients. So if you have a high-risk patient, you get scheduled with more time with that patient. And that visit, the goal of that visit, the primary goal of that visit is to establish a relationship. And so that high-risk person knows that when they get sick or they're not feeling well, the person they want to see is their primary care clinician. And so the goal is to get them engaged with the care team and their primary care provider. And then really during that visit, because you have more time, you can address all of these core issues that they have. You look at their problem list, you look and see what are the significant medical conditions that this person has, and develop a care plan for each one of those problems during that visit. So that when the patient leaves, they know what they're supposed to do for each of their conditions, and work that out with that patient so that there's actually a plan that they can follow through on. This is an example of one of the problem lists from one of the docs from East New York, who does a really great job of documentation of the care plan within the problem list, which is another piece of training we've done with a lot of your clinicians, is how to use the problem list as a tool for communication across the entire care team. When you write your notes, you know that those are clinical encounters. They get buried in a whole list of clinical encounters. It's hard to track what the care plan is for a specific problem just by looking back through notes. But using the overview feature within Epic, you can actually use that overview feature to be the updated care plan for each problem. And there's some very slick tools to actually import that into your documentation very quickly. So those care plans are really key in order to know how to manage those patients. And then this high-value visit is also meant to really close care gaps, to make sure that all the preventive services are being done and being ordered and being executed on. And this is getting where the care navigators work to get those patients scheduled after that visit. And really, the other thing is to anticipate the next care needs. Like what's going to come up next for this patient? When do I need to see them back? And making sure there's a good follow-up plan. And our primary goal, though, like I said at the beginning, is that we want to make sure that we build trust with that patient, because one of the big problems that we see within many health systems is the leakage problem. People go and just go see whoever they want to see if they don't have a trusting relationship. And for those of us who've done family medicine for a long time, a lot of your patients, they don't want to see anybody else but you. And I've had patients, when I was working in Seattle, we had an inpatient service just like you do here. I go to the floor to see my patient who is hospitalized, and they've seen like 6 other doctors that morning. They've seen every resident, they've seen the specialist, and I walk in the room and they go, here's my doctor. It's like they ignored all the other doctors who saw them because you're the one that they're connected to, and that's a really important relationship. The other thing we're doing in this process too is we're changing the metrics that we look at. Instead of looking at how many visits you're doing or how many procedures got done and how many RVUs you collected or CPT codes you dropped, we're actually looking at different metrics. We're looking at things that really matter about population health. Like we're looking at how much outreach is your team doing to get these high-risk patients in? Are they getting scheduled? Are you triaging your people based on risk stratification who are getting into the clinic? How many high-value visits are you completing on a monthly basis and tracking that over time? And then we're looking at, too, like how well is the follow-up actually happening? Are they getting back in to see you? So those are the metrics that we're now monitoring across these clinics, and it really creates a different set of goals for your entire team. So as we look at this is an example of some of the reports we're pulling now, looking at how many patients are being seen, the percent of your panel. Are you actually seeing a good proportion of your panel every year? Are you seeing the high-risk patients? Are you really preferentially getting those people who need to see you the most into your schedule? And are they getting a high-value visit where they can actually get their care plan really laid out and then get that followed up on? So these graphs are going to be provided to your clinics, and this is something we want to roll out to every center, especially the residency site too next year, to get to really get your metrics re-thought through about what it is you're trying to accomplish with these patients. So what do we need from you? What do we need from the clinical teams and the providers? Is the reason you're in healthcare is to help people and keep them healthy, right? That's we're not going to stop people from aging. We're not going to stop people from dying eventually, but we can keep them healthy as long as possible. And that's better for not only for the health system, but obviously for the patient, their families, and for our communities. We really want people to buy in and embrace change. This is a lot of change management. It is difficult to make change within health systems. And it's especially difficult in systems that have been embedded in a particular way of thinking for the last 50 years. We need people to lead, we need people to believe, and that's really what we're hoping we can just inspire in your teams, is to really pursue these concepts around being the disease as the enemy, and that we're here to transform communities. So what can you expect in the next 12 months? You know, what we're hoping to see, and we saw this yesterday, when we went around asking people what's working and what's not working, the time we spent on what was working was actually quite a bit longer than what was not working. I mean, it was, you know,
Beginning was the opposite.
yeah, a year ago, 2 years ago, it was the opposite. We heard a lot about what was not working, very little about what was working. And yesterday was, I'd say, like 70-30, you know. A lot of positive comments about teamwork and how it's working better and how they're feeling better about their work. But we want people to feel like their work is really worthwhile. We want patients to see a team that is ready to help them when they walk in the door. And we heard that too. We heard people say, patients feel like they're welcomed here now. They see our teamwork, and that makes them feel reassured that we can be trusted. And that's a really key thing. So we want more engagement from the patients. We really want to build trust with the community, for the clinic that's in their local community, and for the provider and the team that's there. And then in the end, we're going to see is a lower cost of care over time. And what that does, when you guys have a lower cost of care for your patients because you're taking care of these high-risk people and keeping them out of the hospital, what happens is that resource can get put back into your system. So instead of having a staff that's understaffed, you actually have resources to get fully staffed. And eventually we can even add more. Like, can you imagine having a physical therapist or a behavioral health psychologist on site at every single clinic to actually manage some of those problems locally, and having a facility that actually has the space to manage all those things? I mean, all those things happen when you can take the resource and embed it in. And we found, you know, in every health system, there are millions and millions of dollars that are being wasted because of care that's inappropriate or just missing opportunities. And you take those millions of dollars and you put them into a better delivery model, you have a lot more resource to work with. So that's one of our major goals, is to help you get to that point. And then over time, you know, we'll be able to track these metrics, and so we'll be giving you those data reports on a monthly basis so you can see how you're performing. And the key thing for us too is we want to have metrics that matter to you, that matter to us, that matter to your patients. And so keeping people healthy, having them be in that goal, reducing their bad crises, catastrophic medical events, that's what we want to have happen. That's going to save more money.
Is that the last slide?
Yeah.
All right, so, okay. So I want you to remember this day when a couple of old family doctors flew from Washington and Texas to chat with you guys. I kind of wish that I was like a 40-year-old, you know, Asian female who was like really hip and really cool, because I think it would relate a lot more to the people that I'm talking to than some old white guy from Texas, right? But the reason that we're here is because we've lived through, my dad was a family doctor, and he had the relationship that we're talking about with his patients. I mean, he sometimes got paid with chickens and sometimes with tomatoes, because we lived in a kind of a rural-ish environment down in Florida. People could pay when they could pay, they wouldn't pay when they wouldn't pay, but he just took care of everybody and everybody's family. And I got to see that model. In 1995, when managed care came in, and all of a sudden I was a gatekeeper getting paid $11 per month per person to treat people, which really meant that I couldn't take care of anybody. I had no data, I had no information, I was barely making enough to pay my staff, and I'm supposed to be the blockage between a person going to a specialist or getting a procedure and determine 100% what's right with no team-based care. It was terrible. I mean, terrible. And what I saw during that period is people died. People didn't get care. And they were on my watch. And so when I was 36 in 1996, I had 3 people die that were in their 40s that had seen me within 90 days. And I had said to them, how do you feel? And they said, Dr. Conrad, I feel fine. And then they died. One woman was with her 2 children on a hike in Colorado, and she grabbed her chest and fell over, and by the time they got her off the mountain, she was dead. Now, she had high cholesterol. She had a strong family history of heart disease, and she smoked cigarettes. But she felt fine until she didn't. Another patient of mine was a type 1 person with diabetes, and her husband woke up and said, "Sweetheart, would you like some coffee?" and reached over to touch her, and she was room temperature. She died of a massive cardiac event at her night. Her hemoglobin A1C was 10. I had seen her and said, "We need to increase your insulin." She said, "Hypoglycemia events are just too traumatic. I'd rather let it ride at 10. I don't feel bad." And the third person was my best friend, and he was, you know, he had a little spare tire in the middle. He had what today we would call metabolic syndrome. At the time, there was no word for that. And his wife called me and said, "I found him laying on the bathroom floor, blue." And I just called 911 and went to the hospital. He was dead by the time we got there. And I got really, really clear how broken our system was. And we had to do something. So here we are, fast forward, I'm in my 60s, you're in your 60s yet? Yeah. We're in our 60s flying halfway across the United States to come talk to the young leaders in the future. And the people who we've identified because of the system that Medicis have, that you have the full risk and things, if we can help you do things a different way and live a different life than we lived, you won't have those experiences. My daughter's a family doctor, and she's been in practice, sorry, she's been in practice 2 years. And it's so hard to watch her go through the shit, and pardon the French, that the fee-for-service system's putting her through, knowing that she's going to have people that she could have done something about live a better life. But she doesn't have access to data. She doesn't have access to risk scores. She goes in every day and guts it out in the fee-for-service crap that we call healthcare in America. And so Mike and I, and Susan and Larry, we're not spring chickens, but that's because we've gone through the pain of seeing what the fee-for-service system does to primary care, and it is ugly, and it hurts, and we don't want that for you. So I hope you remember the day when a couple of white guys came from across the country to share a different vision of healthcare, because you all are the ones that are going to pick up the mantles. You're the ones that are going to change the system. You're the ones that are going to say, no, people are not going to die on my watch that we could have done something about. All we can do is look back and feel a sense of loss and regret that we didn't have a couple of farts to come share a new way with us. We didn't have a system of leaders like Dr. Gino and Dr. Allen, who were saying, we're going to do things a different way. We're going to help our residents and we're going to help our doctors have a better life and not have to tolerate really the way that we were discriminated against as primary care docs and the system that didn't allow us to serve our people. So you're in a very unique place, a very unique time, with a very unique set of variables, and I hope that you will take the mantle. I mean, we're going to only give you around another 10 years. We'll hand you the mantle, and here's what you have to do. You have to have data. You have to know I feel fine, but I'm not healthy, so that you can act. And this is everybody from your ACR and the telephone reception, people who are at the telephone call center, to you, the clinician. You have to have a flow where you can hand the 23 hours of work to your team, and maybe you do 6 to 8 hours, but they do 6 to 8 hours, because if you take 23, you take 2 off administrative, and you divide it by 4, which is the 4 members on your team. Now we're talking something that's realistic. But you have to engage with people, and you have to be a different kind of leader than the person who just charges through 7 minutes at a time and does things. And so therefore your mindset will be different. You'll quit. Control is a lie. You don't control squat, but you influence a lot. And so does the security guard and the ACR and the PAR and the navigator and the LP and LRN. They all have significant influence, and great leaders bring their willingness to participate and to lead out in them. That's what a great leader is. A great leader isn't standing in the front of the room shouting. A great leader is the person who looks someone in the eye and says, I see you. You did a marvelous thing for that patient. They mentioned how you said hi to them and they felt welcome. Thank you. That's great leadership, and it changes. We've got to have a system to support you, and we've got to work with specialists no matter how much we don't enjoy it sometimes. But so we're going to have to rebuild a new system, and this is going to be your challenge in your lifetime. So I just really want to acknowledge and thank you all for the heart of primary care, for being the next generation of leaders, and for taking on in your careers a new way of doing things. And we'll be here, we'll be around, we are at your service, we love you guys, and we really appreciate the opportunity to hang out and be with you.